Hello and good evening. Thank you for joining us on our 6th Migraine Masterclass today in collaboration between IVPN, NeuroPsychiatry, and the Association of Migraine Disorders. This event is the 6th in a series that are aimed at democratizing knowledge and education on migraine and bringing world experts to you wherever you are in the world. We would like to thank our sponsor, Pfizer, for this great opportunity and for giving us the resources to bring this to you. I'll just remind you that if you do have a question for our speakers, please post it in the question and answer section of this meeting, and we will get back to you, or we are going to answer the questions at the end of each speaker. So for our first speaker, we will be answering the questions at the end, and for our second speaker at the end of their chat. It gives me great pleasure to actually be here with you tonight with a very important subject. We have talked a lot about the science of migraine, and today we're going to talk specifically about the side effects and adverse events and the role that they play in managing migraine, with a focus on CGRP monoclonal antibodies. Our two guests tonight or today, wherever you are watching us from, are Dr. Lawrence Robbins from Chicago in the USA, and Dr. Alessandro Teruzzi from Dubai, UAE. Welcome, our speakers. And I'm going to just give you a small introduction, Dr. Robbins, to familiarize our viewers tonight. Dr. Robbins is an associate professor of neurology in the Chicago Medical School, and he is a professor of research at the Des Moines University School of Medicine. He is the author of 6 books, the latest one being Clinical Pearls, 2nd edition. He held the position of Vice President of the World Headache Society, and he has started a very interesting section in the American Headache Society in 2001, and that is the refractory headache patient. And this is an area of expertise that we were missing, and he was able to bring this to the American Headache Society. He has authored and co-authored 400 abstracts or articles. He teaches neurology, headache medicine, psychopharmacology, and evolutionary medicine. Dr. Robbins, it is with great pleasure that we bring you to our migraine masterclass. Nobody better than you to talk to us about the subject of adverse events and migraine prevention, and how to manage side effects and adverse events in migraine prevention when using CGRP monoclonal antibodies. Thank you for joining us. If you have just joined us, I'm just going to remind you, in the question and answer section, please do write your questions there, and we will get back to them as soon as we finish this. Thank you very much. The floor is yours, Dr. Robbins, and thank you for accepting our invite.
Well, thank you very much. And I'm going to focus here on CGRP monoclonals. I won't really talk very much at all about GPANs. We've not had much problem with the GPANs. It's really been more the monoclonals. And the focus of the talk really is what we have to do about studies, why they miss the adverse effects. These are not bad drugs. I do use the CGRP monoclonals. My issue is where they should be put. And what I see these days, at least in the United States, is a lot of doctors are using them first before trying anything else for a headache. And I don't think that that's a great idea, and I'll explain why. I'm on a speakers board of several companies. So the efficacy of the monoclonals is held up very well, about the same as onabotulinum toxin A, which we use every day for 26 years now. About 60 to 65% of people get reasonable relief
Dr. Robbins, I'm not sure if we're supposed to see your slides. Are your slides supposed to be up now?
Yeah, they are.
So we can't see them on our screen. Wondering if
Oh,
you need to just restart sharing them. Sorry for the interruption.
let me see here if I have to reshare. Sorry about that.
No worries. Yeah, now we can see them. If you can just, yeah. Perfect. Thank you very much. And sorry again for the interruption.
Thank you. Let me minimize, trying to minimize the screen there. Aha, no. There we can. Sorry about this. I'm trying to minimize the screen. Somehow I'm not able to do it.
It looks good. I don't know if you can move the slides. It looks perfect.
No, right. Everybody's picture is very large on my screen, and for some reason, having
Oh, you're
trouble.
not able to see.
There's a small pen at the bottom at the border of these people. You can just press on that to minimize it.
No, right, but it keeps going away from me. Okay, can you still see now?
Beautiful. Perfect.
Okay, great. So sorry. So the efficacy is held up pretty well. Short-term safety is what I'm focused on here of the monoclonal antibodies. There's a lot of adverse effects we'll get into. Long-term safety, though, we don't know. It takes years to figure out some of these drugs. And I always say use new drugs a lot while they're still safe. We just never know. But I do know that CGRP has been important since the Cambrian period for 450 million years in most animals, and we ignore evolution at our peril. So before these came out, 4.5 or almost 5 years, actually 5 years ago, was Erenumab. I wrote an article about all of the good and bad things that CGRP does. And it's frightening because CGRP does a lot of good things. And I'll go over those briefly here. So CGRP is important in hypertension, in preventing more severe MI as a vasodilator. It's important in aortic stress and worsening cardiovascular disease under stress. These drugs have not been tested under cardiac or physiologic stress. We can see worsening cardiac disease without CGRP, and it has protective effects on the myocardium. So we just haven't tested these. Going north to the brain, could lack of CGRP lead to more severe stroke and reversible cerebral vasoconstrictive syndrome? I did have one patient with definite RCVS after a monoclonal antibody, after CGRP. Pulmonary hypertension can be increased. CGRP is good for those with pulmonary hypertension. We do see a lot of CNS effects, and this is a quandary. Why? We see anxiety, depression, fatigue sometimes, insomnia, irritability, sometimes increased headache. One possible explanation, the blood-brain barrier is not really adequate in certain areas, the area postrema, these circumventricular organs around the ventricles. So the area postrema is crucial in nausea and hiccups. And I've seen a couple cases that I think were due to the CGRP meds. Part of the hypothalamus, the posterior pituitary, the pineal. So we don't get much penetration of the CGRP mAbs formally. You usually need more penetration, significantly more, to have a clinical CNS effect. But maybe we're getting an effect also through trigeminal vascular pathways or downstream. CGRP, though, is ubiquitous, not only through the CNS, but most organs. And we've not seen adequate hormonal studies or almost any hormonal studies. And they're starting to be used in studies anyways in children and adolescents. And I have used the CGRP monoclonals in some adolescents who are very refractory, but they really haven't been tested. Outside of hormonal, the long-term effects of these in children and adolescents, as I'll mention in a minute, CGRP is important for bone formation, and we just haven't tested them in this age range. CGRP is ubiquitous throughout the GI system. It helps in various things, motility, mucosal protection. So constipation is particularly bad, probably more with Ireneumab. We've also seen diarrhea. Whether ulcers are more difficult to heal, it's not been looked at. And there's a lot of questions. Should those with inflammatory bowel disease maybe be excluded from these drugs? CGRP is crucial for tissue and wound healing. That's not been looked at. Skin regeneration, thermoregulation, and very importantly, burn healing. What if somebody gets a moderate or severe burn and they're on a CGRP? These monoclonals are in your system. The half-life is 28 to 30 days. The half-life of the Gepants, Rimegepant, Atogepant, Ubrogepant, are really 12 hours or so, and you're not taking them every day. So I'm not so worried about that class. These are large molecules. The Gepants are small molecules. So CGRP does have an important role in bone metabolism and new bone. Dialysis could be a problem with CGRP. It's protective for kidney disease and during sepsis. So you're getting the idea from head to toe. We're blocking a molecule. Sure, it does good things for headaches, and I like that, and we use them. But we do have the negative factors that have not been looked at. CGRPs in the pancreas, how about effects with diabetes? Now, pregnancy, the effects are unknown. In theory, it's possible that CGRP blocking and the monoclonals might be worse later in pregnancy with cervical ripening, et cetera. As you know, with pregnancy, we look at several factors. We look at immediate effects with birth defects, cardiac, and craniofacial. And then over the next 18 years, we look at ADHD, we look at behavior, we look at IQ. So medicines such as valproate, for instance, sodium valproate, valproic acid, increases all of these. It increases the risk for birth defects, but also, and depends on what dose, but IQ is lower, we have behavioral issues, and we have increased ADHD. Even acetaminophen, Panadol, ADHD is increased with frequent acetaminophen use during pregnancy. So we just don't know. It's going to take a while. Eventually, we did get information, some on the triptans, and there's been pregnancy registries going back to the 90s on sumatriptan and naratriptan. And these do appear to be relatively safe. So certainly during the second trimester, sometimes we use these. But the CGRP meds, it's going to take decades to figure this out. CGRP also declines with age. And are we going to have more risk after age 70 or so with cardiovascular? Now, the studies really missed the adverse effect profile. The CGRP studies came out, the phase 3 studies, with clean package inserts, very little, just hypersensitive reactions. And as I'll mention, we've seen many, many side effects. And how did this happen? So after a drug comes out and is approved, how do we piece together the true adverse effect profile? And I really am focusing more on adverse effects, which is what is reasonably, that we think is reasonable from the drug, that the drug actually caused, as opposed to adverse events, which is anything on that drug. So that's why you see a lot of package inserts with headache and upper respiratory infection from a drug, even though it's not causing those, it's adverse events. But I think adverse effects are much more important. But after the drug comes out, we look at the websites of the European FDA type and Canadian and United States, post-approval studies, high prescriber chat boards, which I think are very valuable, and patient chat boards I'll mention. They're not worthless at all. Our personal experience, of course, if we're a high prescriber, and correspondence and meetings or with other patients and physicians. So we piece it together. So it's been 5 years now. We have data from the FDA through end of March of this year, and we have 67,000 adverse events. This is about the largest number of any class that I know of that's come out. Serious, though, is almost 10,000. So serious, there are several definitions. Life-threatening or hospitalization is one definition, or something requiring intervention. And one expert has done some research. He felt that only 1 to 7%, 1% is more common, of serious adverse events are actually reported. So we don't know how many, but this is a lot. These numbers are actually about the same as onabotulinum toxin for 30 years. So we have 30 years of onabotulinum toxin. The events reported are about the same as the 4 years of the monoclonals. Very high numbers. Now, irenalimab has the most, but I don't think that irenalimab really is any more or less safe or more dangerous or anything than the others. It just was the first out, the most reported. And I do think that constipation's more with irenalimab, but the others are catching up a little bit. Constipation can be pretty severe with irenalimab, and of course the studies missed it. Now there's a warning in the package insert. I think the companies do a good job. The studies are run by contract research organizations. The problem really lies, and I'll mention why, in how we acquire these adverse events during the studies. And that has to change through the organizations like in the United States, the FDA. So post-approval, we look at studies. We did out of our office a checklist study where I think if we don't use a checklist, we're going to miss the adverse events, adverse effects, which is going over common signals or probable adverse effects from a drug with a patient. So we took patients and we asked them in the usual way that studies ask them, 119 patients on the monoclonal antibodies. We asked them, well, how are you feeling? Any side effects, any problems? Are you tired? And then we presented a checklist of 18 very well-defined possible adverse effects or signals, as they're called. And we went over each of them. And if patients said, oh yeah, I have joint pain. Oh yeah, I have hair loss or muscle aches. We then went over the history and what happened to make sure that it was from the monoclonal antibody. And what we found was that 66% of the patients had at least one adverse effect that was not revealed upon the initial questioning. So if you don't use a checklist, and the studies don't, you're going to miss them. We had a number of patients that had more than one and multiple adverse effects using a checklist. Another avenue to explore is real-world experience. There's been some studies, we need more. Robley et al. Did not find all that many adverse effects, but they did have 12 discontinuations due to adverse effects out of 118 patients. Another study did find a very high degree of non-serious adverse events. And there was yet another study that did not show that many discontinuations. So it's been a mixed situation with mixed results. We need more real-world experience from high prescriber clinics looking at, say, 500, 800 patients. So I think most studies miss the adverse effect profile. Efficacy holds up pretty well. This is not unique to the CGRP monoclonals. The companies are doing reasonably well with the studies. It's just we need to change. So the signals that are in the package insert now, hypertension has emerged as a signal, and the monoclonals seem to increase blood pressure, maybe 3 points, maybe 4 points. That's significant. And if it's a little bit more in one individual patient, that can be significant over 10 or 20 years. I quote a leading expert in acquisition of adverse events in clinical trials. Thomas Moore was considered one of the United States leading experts, and he was astounded when he reviewed these several years ago at the sheer number of adverse events due to the monoclonals. We also look at physician communications on our chat boards. We have one chat board with maybe 400 providers that's very active. And I look at what they say. For instance, one emailed me that they were giving a monoclonal. It was actually the doctor's wife, and she had very severe nausea and vomiting right after going on the monoclonal, had several negative workups. And I said, it's probably the area postrema syndrome. But unfortunately, with the half-life of the monoclonals, it's going to take months, may take 5 months to completely get out of the system. Interestingly enough, patient chat boards, we looked at almost 3,000 comments and parsed them out, identified 490 highly believable comments. Highly believable would be, I'm 58 years old, I never write on chat boards like this, I've never had depression, I went on one of these injections, and I've been severely depressed, and I went off and the depression went away, and I went back on and the depression came back. That's a highly believable comment. Interestingly enough, the adverse effects of these patient chat boards lined up really well with our other sources, like the FDA and the studies, et cetera. So in our experience, we've seen a large amount of non-serious ones. In 25 years, 27 years actually of using onabotulinum toxin almost every day, I've had only a few adverse effects, no serious ones. But in our little clinic here, we've had 4 or 5 serious adverse effects from the monoclonals. Early on, we had a 21-year-old with a stroke. She can't write, she has agraphia. A 61-year-old with reversible cerebral vasoconstriction syndrome. Another older woman with severe joint pain, she had to be hospitalized. And then a curious 30-year-old with a number of symptoms. They resembled multiple sclerosis, but it required 2 hospitalizations. Patient communications also, they email me, patients all the time. I get emailed because of our blog, et cetera. And they say they've never had problems like severe joint pain or muscle pain, and now they are from the monoclonal. So I do listen to these patients' communication. Obviously, it's anecdotal. So putting all of these lines of evidence together are signals that have emerged, I think, in order of frequency from the monoclonals. Constipation, number one, maybe 20, 25% of patients. Anxiety, injection site reactions, insomnia, hair loss, joint pain, muscle pain or cramps, irritability, depression, increased headache, nausea, weight gain, hypertension, and sexual dysfunction is classically minimized in studies. People don't mention it. They don't bring it up. So you actually have to ask about it. And sometimes, you know, it's been reported tachycardia, rash, diarrhea. So the problem is the studies don't use a checklist. I'll go over each of these in a minute. They're underpowered for number of patients and for time. Symptoms become disaggregated. the patients tend to be milder, and the patients they have less comorbidities in studies. So without a checklist, you're going to miss the studies, miss the adverse effects. The studies are underpowered for number of patients. So if you have 1 in 1,000 patients with a true adverse effect, you need 3,000 patients to uncover one case with a 95% probability. And to uncover 3 cases, you'll need 6,500 patients. And most studies have 500 to 1,800 patients. They don't have these numbers. In time, we really need years of study. And the long-term extension studies, I think they're cherry-picked because the patients are doing well, so they're not going to show anything. Symptoms become disaggregated. So you might say you're fatigued. I have malaise. The next patient has somnolence. Each of these might be 1 or 2%. So it gets really not reported. But when the true incidence, we're all talking about the same sort of feeling, might be 4 or 6%. You can re-aggregate after the study, but that's fraught with problems. Several years ago, I presented slides like this in Controversies in Neurology. Before the debate, 94% of the audience, this is international audience, thought that these were very safe. And after the debate, only 42%. So it shows we need to be doing a better job of telling physicians and providers and neurologists that these possibly have these side effects so that patients don't go there, complain about hair loss or muscle or joint pain, and they're dismissed and minimized, and they're told that it can't possibly from the drug, so they continue on the drug. In real life, these monoclonals have had a lot of side effects, and they tend to be minimized by the providers. The efficacy is held up well. I like the drugs. It's just, where do we use them? And I do feel they should probably be used after a few other medicines haven't worked, our traditional medicines, and ideally on a botulinum toxin, which isn't available everywhere, I know. But what I do see now is that a lot of patients are going on these drugs, on the injections right away before they've tried anything else. We do also need our trial experts to change how adverse effects are collected in studies. So we're talking about short-term safety. Long-term safety, we don't know. And sometimes it takes 20 years or 30 years, as you know. I think these are going to stay on the market, but I think more is going to come out over time. And lastly, evolution has decided that CGRP is important in most systems for many, many years, and we're blocking it in young people and sort of closing our eyes, hoping that nothing bad happens. And I always say we ignore evolution at our peril. And for that, I want to thank you. And we welcome any comments or questions. Thank you very much.
Thank you very much. This was very eye-opening for me, specifically as a practitioner with people living with migraine, because on patient boards, as you said, we hear all sorts of things, or patients in person tell me things that they say. They go to their family doctor and they say, well, I'm losing my hair. And the doctor says, you can't be losing your hair with this medication. And then on the board, on patient boards, they see that a lot of people are getting the same side effect. So how do we, as practitioners, as healthcare providers, how do we ensure that we are not part of this? Let's dismiss it because it's not in the NSAID leaflet. How do you manage this as a practitioner?
Well, I think we always have to legitimize what the patient says. And sometimes it's not from the drug, or we know that it's something else. But if we don't know, we have to leave open the possibility. I think that patients have expressed online, and to me, a lot of anger about that, not just with the monoclonal antibodies, but when their concerns about a possible side effect are dismissed. So I always legitimize it. but I'm not afraid to tell them, I don't know.
Yeah. And I think that is acceptable to patients. If someone comes, like one of the side effects that is reported with some of these medications is weight loss. But I have patients who come and tell me, since I started this, I've added at least 7 kilos. And the 7 kilograms are a lot. And they go to their family doctor and they say, no, that's not why this is happening. You must be eating more. There must be something else happening. So I think the first thing is, I don't know. And unless us as healthcare providers start reporting these side effects, we will never know. And this is possibly something we need to take a more active role in, to collect that real world experience that you were talking about, in recording and reporting any side effect, even if it sounds, or adverse event, even if it sounds unlikable or unlikely. I have a question from one of our viewers that I would like to present to you. But in the meanwhile, if you are joining us now and you have questions, please make sure that you do post your questions in the Q&A section of this chat. So I have a question around the effects on skin. Are you seeing any increase in psoriasis in your practice?
So in my practice, I haven't seen that, but I haven't been asking either. And the effect on skin is very interesting. I've seen a couple on the chat boards, and you had mentioned the weight gain is really interesting. I've definitely seen it in a few patients and heard about it. And the mechanism, as I mentioned, the blood-brain barrier is not all that adequate around the hypothalamus. Maybe it's getting in the feeding center of the hypothalamus, or an effect on orexins. We just don't know. The effect on skin, I think, is really it's a great question, worth looking at.
But the idea of weight gain, we also are not asking patients, do you feel swollen? Do you think there's a little bit of water retention that's happening there as well that is adding to that? Do you feel that this is a question that we can ask, especially with people reporting weight gain with a lot of these medications, alongside saying, yeah, well, it's a justified question? What do you think of that?
Some medicines you see edema, and it's common, pregabalin, verapamil. I have not seen that with the monoclonal antibodies.
Okay.
I think the weight gain we've seen is real weight gain. And as you know, whether it's from a drug or not, it's tough to lose. Nobody wants to gain weight. And what I've seen on some of the chat boards is, occasionally, it's not common, is moderate to severe weight gain, 15, 20 pounds. And then nobody's happy. They're not happy with us at all.
No. I have a couple of questions. One is around GPANs. Do GPANs cross the blood-brain barrier?
Well, that's a good question. They're small molecules. I don't know the answer as far as penetration, but from the GPANs, we've not seen much in the way of side effects, tiredness and nausea, occasionally others, but they've held up pretty well. Part of it is that even if you're on rimegepant every other day as a preventive, it's only in your system 25% of the time or so. It might have a 12-hour half-life, run it every other day. The monoclonals are 24/7 constantly. So I think I'm not as worried about the GPANs and long-term adverse effects, but we may find out. And there's a lot of patients now on a monoclonal antibody, CGRP, and a GPAN. And we don't have long-term safety studies on that combination. Now, the other side is that headaches ruin people's quality of life. And when they're moderate severe and nothing helps, and anything that is effective, like the monoclonals, is good. But I just am not worried about the GPANs nearly as much. Yeah.
And we haven't seen any sedation. We haven't seen anything that might be a red flag for us with these medications so far? We haven't seen sedation, we haven't seen impairment or cognitive impairment, we haven't seen sleep disturbances with them. Would that be indicative that maybe even if they do cross the blood-brain barrier, there's no real effect in terms of what it does to them circulating in the brain?
Right, right. We haven't seen very much CNS except tiredness here and there. We see more CNS effects from triptans. Some people are confused or tired or washed out. We see more side effects. There was one study that compared triptans and gepants. The triptans are a little more efficacious, but more side effects. And I think our clinical experience has held up to that view.
And how do we know if the fatigue that you see with these medications is not part of the course of the disease? Because if you take nothing and you let the migraine just take its course, the next day you're tired and you feel that you need to sleep and you have no energy. How do we differentiate between adverse events and between the course of the condition or the disease?
Usually just asking the patient, if you don't take this or you take something else and they say, I don't have a postdrome or I'm not tired. And usually the patient knows and will tell you that it's directly from the drug, and it doesn't happen when they don't take the drug. But sometimes we don't know. They're washed out, and there's a lot of reasons. The migraine, you can have the postdrome and lack of sleep, but also the drugs. So sometimes it's hard to know, but usually asking the patient, they'll say it definitely, when I take it, it makes me tired. We see more of that with the triptans.
Yes, absolutely. I have another question here. What do you think about ditans or ditans versus monoclonal antibodies in terms of side effects, adverse events, and efficacy?
Well, lasmiditan is the ditan that's been marketed, and I think it's a reasonable drug. We had on our chat board, a lot of comments about them. Some physicians have seen a fair amount of dizziness and side effects or other side effects, and some haven't seen that many, but they don't affect cardiovascular status. So in higher risk populations or older populations, but I think clinically and listening to the physicians, more side effects with ditans, reasonable efficacy, but they're going to be a small niche product. If somebody can't take a triptan, and triptans for 30 years are really safe. We don't want to use them in very high risk situations. We can get rebound headache from triptans, not that often. Rebound withdrawal headache is a little overstated. But I think there's a role for lasmiditan, ditan, but it's going to be small. We definitely have more side effects than the gepants, which just generally, sometimes they don't work, sometimes they work great, but we don't usually hear very much about side effects. You hear more from the lasmiditan.
And the thing is, we don't have head-to-head studies between gepants and ditans so far, or even triptans and ditans so far, talking about efficacy. Not that I know of. I don't know if you have another opinion on this.
No, I know that there's a head-to-head with, I think it's one of the monoclonals that's going to come out with a gepant, I believe. But most of the time they don't do these head-to-heads because it doesn't particularly help the company long-term. It would be really nice to get head-to-head in these, but you would need a lot of patients. You would need a powered study, really. So it depends philosophically how you look at anecdotes. Some look at anecdotes as just stories told by high prescribers, and the plural of anecdotes is not data. That's true.
Yes.
But what would we rather believe? 2,000 anecdotes from a chat board or something from high prescribers, which might encompass 10,000 patients, or from a small study that, that's limited in who they pick. And, so I think anecdotes are really worthwhile anyways.
And it's the selection of patients in clinical trials is not really reflective of comorbidities in the real world. So we don't know if someone has a comorbidity, if this affects how they react to a medication, or they don't do any studies. Like the studies try to exclude a lot of patients who have comorbidities, and that is not representative of real world experience.
Absolutely, absolutely. And when we're looking at adverse effects, they've excluded them, but the patients do have this and that. They have cardiovascular, they have diabetes, they have hypertension, they have depression. So as you mentioned, you know, it's not real world, but I understand they want to get a clean study. They're not doing it to artificially get good results. They really want to see the effect of the drug. And I understand they want to minimize other drugs. But the result is that we need more and more studies. We need more and more time. Time tells a lot about these drugs and safety too.
Yeah, I have a question that I've always wondered about, and this person is, our viewer is asking it in a different way, but I think I can say it: monoclonal antibodies and the risk of infection. Like in other conditions, if you are on a different kind of monoclonal antibody, we always say you need to ensure that their vaccinations are updated before you start it to prevent infections, and non-routine vaccination, like for things like shingles, like pneumonia, all sorts, HPV, all sorts of non-routine vaccinations. Do we see also an increased risk of infections, and is there a need for vaccination?
Well, it's interesting. I think it varies on which monoclonal antibody. That's been looked at extensively with the MS, the multiple sclerosis monoclonals, particularly with COVID and the risk of COVID, because the patients are a little immunocompromised anyways. I've not seen increased infections with these, but in theory, they can interfere with wound healing and with if you did get sepsis. But I haven't seen regular infections worse. Now, on the other hand, most people who take monoclonal antibodies for migraine, CGRPs, are relatively healthy, younger patients in general. But it's a very good question. I think it depends on which monoclonal antibody, and that's varied among the MS drugs, for instance. Some of them have an increased risk, and several have not, I believe. So, but we haven't seen it with these drugs. It doesn't mean that these drugs are, say you have an immunocompromised population and they're on one of these. But I do like monoclonal antibodies. You don't have, they're broken down by the reticuloendothelial system, carried away by lymphatics. You don't have the drug-to-drug interactions and through the liver, like we see with many of the others. So, but it's a very good question. We haven't seen much with the CGRP monoclonals.
And
like
would
that.
there be a patient that is, let's say, immunocompromised, or that has a hepatitis, TB, anybody that you would exclude or you would need to screen for before you start a monoclonal antibody?
Well, I think it's a great question, and it hasn't been studied. That's the issue.
And I think in our case, we do not screen for these conditions. In Canada, we do not screen. We do start on a monoclonal antibody without having to screen for these. Usually we start them, and I haven't seen anything that says we do need to screen, but it's very interesting, and I think it's a great question. The other question that we have here is there the switch between these monoclonal antibodies when there is an adverse event? I think I'm trying to rephrase this. How do you switch, and how do you make sure, like, if they do get some adverse events or some side effects, how do you switch? And is this something that you do? Do you switch to the same group, or do you switch to something else?
Well, it's a great question. There are people who do better with one of these than another, but might have, say they have more constipation from arenyumab, then they go to one of the others. And their efficacy isn't as good, so we go back to Arenumab. Sometimes the intravenous form of these might work better. You get higher blood levels, you get 100% bioavailability, and it works faster sometimes. But I tend to use other things, and onabotulinum toxin and the G-PANs before I get to these. And then just like every migraine drug, sometimes these wear out and they stop working. So if you stop them for a while, maybe they'll work again, or you switch. I just switch if at the end of the month. So yes, it's still in their body, but we don't have a washout period. It hasn't seemed to be necessary, although there haven't been adequate studies. So if they took one at the beginning of the month, in a month, 30 days later, we'll start on a different one. Sometimes we start because of finances. One is paid for better than another. Generally, when do you quit on CGRPs? If one or two G-PANs haven't worked and also a monoclonal or two haven't worked, is it worth trying the intravenous? That's a question. But generally, we don't want people to keep trying things for a year. I think that if CGRPs don't work, the G-PANs and a monoclonal or two, they're just not going to work. And we just go back to older things or onabotulinum toxin or some refractory medicine. So there's a lot of practical considerations with these drugs, how to manipulate them. And there haven't been well-done studies on switching like that.
I think the next question, the question is, what is the incidence of migraine in children and safest drugs? And I think I would like to restate this into monoclonal antibodies and children. We know that they are not indicated in children. What are the safety concerns in children, and what adverse events do we need to anticipate?
So well, it's common, 1% of 6-year-olds have migraine, at least 4% of 10-year-olds, but mostly it's adolescents we're talking about. You can use onabotulinum toxin. It's not officially indicated, but you can use it in kids. It's used for cerebral palsy down to age 3. If you use low doses, it's really safe in kids and sometimes works pretty well for refractory, but usually you minimize medicine and you use mild medicines, all the usual pediatric approaches. As far as the monoclonals, I have used G-PANs in kids. If other things are not working, I'm not so worried because they're in your system for a number of hours and then they'll use it once a week or something. But the monoclonals, we have had some adolescents. They haven't been tested. I worry about bony metabolism. They interfere with bone growth. CGRP is crucial and we're blocking it. Hormonal effects, we just don't know. And I've asked all the companies, I don't think they've published very much at all, if anything, in hormonal effects. So they are a last resort. But as you know, when you have a very refractory kid, we take a lot of approaches outside of medicine and psychotherapy and relaxation and everything. It takes a lot of people to help a 15-year-old with severe headaches. And a lot of times there are psychiatric factors, but we've had some success in 15, 18-year-olds, 17 with monoclonals. It's off label. But my idea is to cycle them in and out. I'm not going to keep them on it for years and years and wait to see long-term side effects. I'll use them for 6 months, 9 months, and then try to get them off is the idea.
Okay. I have one more question before we finish this part, and that is, the question says, are there any guidelines in terms of drug of choice in relation to treat young age, 20 to 30, versus geriatric patients? And maybe the question is, I know from a lot of from our guests and from a lot of the practitioners I've talked to, is that monoclonal antibodies and G-PANs seem to work better in younger versus refractive and older patients. Is this your experience? Do you feel that there is a difference?
It's a very interesting different ages. And as far as different ages, we do, and not enough has been written about migraine prescribing, but prescribing in general. 0 to 12 is different than 12 to 18. And then you have basically 18 to 40, and then 40 to 70. And then the old, 70 to 85, your geriatric prescribing is much different or somewhat different than the very old, 85 to 100 plus. You generally are using much lower doses at older age ranges for a lot of reasons. You have different volume of distribution and this and that, this and that. So I think age is a key driver of where you go. In general, the more refractory, I separate, and I've done some articles, a lot of articles on refractory, what to do when nothing works, but I've separated people into mild, moderate, and severe refractory. So somebody who hasn't done well for a year with any preventive might be mild refractory technically, but a patient who's 55 years old with a lifetime of headaches and opioid dependent, multiple psychiatric illness and multiple central sensitization syndromes, fibro, chronic pelvic pain, our goals are different and they're not going to do as well. Absolutely. Yeah. But there are 60 to 90-year-olds, 60 to 80-year-olds who've done well with monoclonal antibody for CGRP or with GPANs. So I don't think it's necessarily true that younger people do better, but it's interesting. The studies generally haven't looked at that at all, but our age does influence, and other medical conditions, of course. There's no good algorithm for headache patients. We put about 30 things together, many, many various factors, and we come up with a top 10 list for this person versus that person, and it varies widely from one person to another.
Yeah, I thank you very much for this very comprehensive talk, for this for answering all these questions. We've had a lot of questions, and I think there are still a lot of questions around this, but we have had a great overview of the side effects and adverse events in migraine prevention and the use of CGRP monoclonal antibodies. Thank you very much, Dr. Robbins. We hope to see you again on IVPN and Association of Migraine Disorders masterclasses. We wish you all the best, and we thank you for your time. I'm going to go next to Dr. Alessandro Teruzzi. Am I saying your name right, Dr. Teruzzi?
Perfectly.
Thank you very much.
Thank you
for joining us today. Dr. Teruzzi is currently the head of neurology department at Mediclinic City Hospital, and he is the clinical lead and head of medicine Mediclinic Comprehensive Stroke Center at the City Hospital in Dubai. Dr. Teruzzi graduated from and underwent specialist training in neurology at the University of Medicine and Surgery of Milano, Bicocca, am I saying this right again, in Italy, and where he also obtained a second level master's degree in cerebrovascular diseases. He was working at the neuroscience department of Manzoni Hospital as a stroke neurologist, where he was the former director of the Headache Center before moving to Dubai in 2017 as a consultant neurologist. He's also well trained as a neurosonologist, expert in ultrasound Doppler investigation of the carotid and vertebral arteries and transcranial echo-color Doppler. Since 2019, Dr. Teruzzi has collaborated with the Mohammed bin Rashid University as an adjunct clinical associate professor, and his current or primary interests are the diagnosis and treatment of headaches and cerebrovascular disorders. We welcome you to IVPN and the Association of Migraine Disorders, and we're looking forward to hearing your experience. And of course, I'm going to remind our attendees, if you have any questions, in the question and answer section, and we're going to answer them after the presentation. The floor is yours, Dr. Teruzzi.
Thank you, Dr. Hiba, for the very kind and nice introduction. Let me share my screen. Okay, so after this very interesting and stimulating lecture about the possible side effects of the monoclonals, we are going to talk now about a different category of anti-migraine medication, particularly about rimegepant, so Nurtec as its commercial name. This is the disclosure. So Nurtec is the first and the only of its kind that is able to treat at the same time both acute attacks and to work also as a prevention, as a preventive medication. And while the ODT should stand for orally disintegrating tablet, could also mean only dual therapy, because as I was saying, it's able to be used in both situations, in both conditions. Basically giving a great advantage to our patients that are able to treat their migraines with one single molecule and one single tablet. As we know from the American Headache Society, the criteria to consider successful and ideal medication for the treatment of migraine, we are talking now and we are focusing more on the acute phase of migraine, is that this molecule ideally should provide rapid and consistent freedom from pain and should be able to restore the ability to function. So the first point is should be fast and consistent to give pain, freedom, and reduction and freedom from the most bothersome symptoms. As you know, nausea and especially photophobia, as well as also phonophobia and osmophobia, but specifically photophobia, are very, very disturbing and disabling for our patients with migraine. This ideal molecule should be able to restore the ability to function. So the patient should not only have a reduction in the intensity of the pain or of his bothersome symptoms, but should be able to be functional again, to go back to his working activity or daily life activity. Not only should be effective with the first run, so with the first tablet, minimizing the need for repeating the dosing or minimizing the need to go for rescue medication, like having to take several other painkillers after the first drug of choice. And due to his effectiveness, should also be able to reduce somehow the healthcare resource utilization. And of course, safety must be guaranteed, so minimal or no adverse event should be reported by the patient that is using this ideal molecule. And of course, this is quite evident. All people with migraine should be offered at least a trial of acute treatment, especially when the frequency of migraine is low, and eventually to be approached for prevention if the frequency is higher. Blocking the CGRP is the way that Nurtec works, because it is a small molecule CGRP receptor antagonist. And it's able to achieve not only pain reduction, but also pain freedom and freedom from the most bothersome symptoms. Nurtec is a highly selective molecule in its binding to the CGRP receptor, and it's able to affect the vessels, for example, without giving vasoconstriction, as we do know instead is the typical mechanism of the triptans. So it's able to inhibit vasodilation without giving active vasoconstriction. It's also able to inhibit neurogenic inflammation, and is also able to minimize or inhibit the exaggerated pain signaling that is happening from the periphery to the central nervous system through the trigeminal system. The other very important information that we have to always remind when we are talking about gepants is that the way the small molecule CGRP receptor antagonist work and the way Nurtec it works is able to provide a relief from migraine without causing medication overuse. And we'll see later why and how this was documented. What about efficacy? Of course, there were several clinical trials that documented efficacy of Nurtec in acute migraine management, showing superiority over placebo at 2 hours for the acute treatment of migraine. The primary endpoints were pain freedom and freedom from the most bothersome symptom. This is very important because if you remember, all the clinical trials with triptans were targeting pain relief, which is a secondary endpoint instead for the clinical trials with Nurtec. And Nurtec was able to, of course, show dramatic superiority in terms of pain relief compared to placebo. 60% of the patients achieve easily pain relief, but was also statistically superior, giving pain freedom and complete freedom from the most bothersome symptoms against placebo with a single dose of medication at 2 hours. The other very peculiar point of rimegepant, of Nurtec, is that it is able to provide sustained pain relief from and after a migraine attack up to 48 hours with a single dose, with a single tablet. For the clinical trials, it was evident that among those patients that achieved pain relief at 2 hours, so the 60% of the patients that were using Nurtec, 71% continued to experience sustained pain relief through up to 48 hours. And this was once again superior against placebo. Not only, but 86% of the patients who took Nurtec did not need to take any other kind of preventive medication, so no need for rescue medication, in the first 24 hours after taking one single dose of Nurtec compared to placebo, again, statistically superior. So this molecule is able not only to give pain relief easily, pain freedom and freedom from the most bothersome symptoms in a superior way compared to placebo at 2 hours, but in a percentage of those patients is able to give also sustained pain relief and the avoidance to need any second dose or rescue medication or further painkillers. This is a slide that is showing basically sort of timestamps about the achievement of the results after taking a single dose of Nurtec for migraine acute treatment. As you can see, both pain relief and return to normal functionality from a pharmacological point of view is achieved in 15 minutes. And from the clinical point of view, patients report improvement in the scores for pain and functionality already starting at 60 minutes after taking it. And the effectiveness becomes complete and full at 2 hours after a single dose. But as we have seen, and we have just heard, the efficacy keeps going on for those patients who achieve, for example, pain relief. 71% keep sustaining, keep maintaining this pain relief for up to 48 hours. And the same is for the recovery of a full functionality and the freedom from the most bothersome symptom. So we can summarize saying that freedom from pain at 2 hours, of course, is possible with Nurtec, but we can also expect our patients to have sustained response up to 48 hours after a single dose of rimegepant of Nurtec. 68% of the patients taking Nurtec who experience pain freedom, so we are no longer talking about pain relief now, we're talking about pain freedom. 62% of the patients who are able to achieve pain freedom at 2 hours kept being free from pain up to 48 hours. And this was again statistically superior to placebo. Overall speaking, 35.5% of patients taking Nurtec, 13.5 patients taking Nurtec experienced pain freedom from 2 hours and a smaller percentage up to 48 hours, compare only 5% of the patients that were taking placebo. So nearly 3 times the number of patients were having sustained pain freedom on Nurtec compared to placebo. The other point is, how does it work if the patient is already on a triptan, or if the patient already failed on one or more triptans? Those could be challenging cases. What to do in a similar case? Can we still rely on Nurtec for acute phase treatment? And the answer is yes. So in terms of efficacy, based on previous triptan response, it was clearly documented that in purple, you've got rimegepant, and in light gray, you've got the placebo arm. As you can see on the left-hand side Of course, rimegepant is superior compared to placebo in achieving pain freedom and freedom from the most bothersome symptom in patients that are triptan naive, so that never tried triptan, so can also be used, theoretically speaking, as a first line of treatment. Still, you've got the same excellent response against placebo in terms of pain freedom and freedom from other symptoms in patients that are already taking a triptan. But what is more interesting is that even if the patient was already failing on a triptan, as you can see on the right-hand side, one or even two or more triptan failure, so what we call like a refractory patients, Nurtec still does work. So the efficacy and the response to Nurtec is not influenced by the failure on a triptan or multiple failure on triptans. So those patients that were responding to triptans or even the non-responders are still a good candidate for Nurtec because they will still respond in an excellent way as expected. So, of course, triptans are still very good molecules. We use them a lot in clinical practice. What are the advantages? What is the edge of Nurtec when we want to use it instead of a triptan, for example? Well, the advantages are several. First is, of course, the quickness of action, the early action that, as we've seen, starts from being already felt by the patient in the first 60 to 90 minutes. And the ability not only to have modulation of the pain from pain relief to actual pain freedom, while we know that the trials with triptans were only targeting pain relief, but also the freedom from the most bothersome symptom, which is something that is not always reported with triptans. And not only, we do know that 42% of patients that are taking triptans, they need to redose, so they take a second dose to have better response. And unfortunately, in a high percentage of patients, from nearly 70 to 80% of triptan users, there can be early recurrence of migraine in the same 24 hours after the first dose, and they have to go for other rescue medication or redosing. While with Nurtec, we are seeing that we can really target a sustained efficacy that can be going from pain freedom up to 24 and sometimes 48 hours, or pain relief that can be achieved up to 48 hours, and also absence of the most bothersome symptoms. In terms of tolerability, we do know that triptans, unfortunately, can have quite frequently side effects, sometimes minor, sometimes more severe. 43% of patients have emergent adverse events on triptans. They can go from the typical constriction in the throat, nausea, fatigue, tachycardia, dizziness, or sleepiness, and are also absolutely contraindicated in patients with cardio or cerebrovascular or vascular conditions because of their vasoconstrictive effects. While, for example, rimegepant, as a most common adverse event is only nausea, that is reported in up to 2% of the patients that are using it for acute treatment. And we have evidence from the long-term open-label 52 weeks trial about the long-term efficacy, safety, and absence of medication overuse induced by the cumulative use of rimegepant. So even taking several doses of rimegepant does not trigger medication overuse at all, which instead we know it's a high risk with triptans. If the patient is taking several triptan doses in the same month, we know that the magic number is reported as in 10 in a month. They can develop a medication overuse headache. And if you compare Nurtec against the other most recent acute phase medication for migraine, that is to say ubrogepant and edaitan as lasmiditan, from the pharmacological point of view, there are differences, and we can play around these differences to use the best molecule for that single patient. The advantage of Nurtec is the onset of pain relief that can start from, you said, 15 to 60 minutes. And with the ubrogepant is noted in the first hour and becomes significant as well at 2 hours. And with lasmiditan, it's already statistically relevant at 30 minutes, but does get better with the higher doses and is not so effective with the lower doses. As we know, lasmiditan comes in a 50 milligram tablet and 100 milligram tablets and can be given up to 200 milligrams in the 24 hours. Ubrogepant comes as a 50 milligram or 100 milligram tablet and can be taken up to maximum 200 milligram in the 24 hours, while Nurtec comes in 75 milligram oral dispersible tablet that can be taken once in the 24 hours. In terms of the sustained benefit, we've seen that with rimegepant we can achieve up to 24-48 hours benefit. With ubrogepant has been documented up to 24 hours. With lasmiditan has been documented up to 48 hours. But where rimegepant does take a further distance from the other molecules is in terms of the adverse events that are reported as being nausea when it is used as acute phase medication, and can be nausea or dyspepsia and abdominal pain for the patients that are using it as a preventive medication in less than 2% of the patients. With ubrogepant, with the smaller doses, tolerability is also excellent and comparable, but sometimes the patient need to reduce, to increase the dose, and sometimes need to reach the 100 or 200 milligram dose, and then is where more side effects are reported in terms of nausea and also somnolence. Lasmiditan, unfortunately, despite having a very high efficacy, pay a big toll in terms of tolerability and adverse events, because the majority of patients will report side effects and will make it very difficult to be tolerated for further attacks, because it can give quite severe dizziness, near fainting sensation, fatigue, muscle weakness, sedation, nausea, vomiting. As you know, there is also a limitation by the FDA. The patient cannot drive for up to 8 hours after taking a single dose of lasmiditan, because it can influence driving ability, and so they are completely inhibited from driving for 8 hours, which doesn't happen with the gepants. That is because lasmiditan does cross massively the blood-brain barrier. And from a, let's say, pharmacoeconomic point of view, we know the gepants are expensive, and they are. So, of course, there are also concerns in terms of the cost that the individual or the society have to face for these newer molecules. But actually, if we look at the proportion and the number of tablets to successfully treat a migraine attack, the ratio, the proportion is quite favorable for Nurtec, because as we can see, rimegepant demonstrated a reduced frequency of redosing, and they use also reduced use of rescue medication. And as we can see, patient with ubrogepant used an average of 1.4 pills per migraine attack, as you know, can be reduced if it is necessary. The same for Revau. They were using an average of 1.35 tablets, because they can take 150, or sometimes they can also take 100. Patients treated with Nurtec were using an average of 1 single tablet per migraine attack. Showed also a good profile from the resources of the rescue medication or need of reducing. So basically, we can summarize saying that statistically speaking, a patient can be in need to use 7, need to use up to 10 tablets of ubrogepant to treat 7 migraine attacks. They will need to use 8 tablets of lasmiditan to treat 6 migraine attacks, and nearly 8 tablets of rimegepant to treat 8 migraine attacks. But as we know, Nurtec is not only an acute phase medication, it's also approved by FDA and EMA to be used as a preventive medication, so can also be used as a prevention. And why this is necessary? Well, because that we know that oral standard of care, so the non-targeting oral medications that we have been using for the last 20 or more years, they do work. They do work, this is absolutely true, but they have quite a delayed efficacy. It takes several weeks and sometimes even months to reach the intended results, or even the beginning of the improvement. A trial of 2 to 6 months can be necessary. Some of them have a very low titration and tapering stage, like topiramate, for example, that has also quite severe side effects if you taper it too quickly. So it's often necessary to taper them slowly and gradually so the patient can stay on the same medication for even a couple of months before starting having any kind of improvement. The other problem is the tolerability and side effects, because the higher the dose of this preventive medication we try to use, the more side effects we will face. And sometimes even with the already small doses, we can have sedation and fatigue, as we do know what happens with the tricyclic. We can have depression or increased weight with calcium channel blockers as flunarizine. We can have anorexia or cognitive issues and weakness and fatigue with topiramate, and so on. So we do know that the discontinuation rate, unfortunately, is high, and the retention rate on the oral standard of care is quite low. It's difficult to have the same patient being able to stay on the conventional oral preventive for long and for more than 6 or 12 months. It's really, really challenging. The majority of patients taking an oral preventive treatment discontinue it within the first 6 months, unfortunately. So looking about the data about the efficacy of rimegepant in migraine prevention, where do we position rimegepant? Rimegepant, as Nurtec, is an efficacious medication for migraine prevention also, documenting a significant 4.3 days reduction in mean monthly migraine days compared to placebo. And this was happening with patients with a baseline of monthly migraine days of 10 per month, and treated with rimegepant compared to placebo. And this result was statistically significant at week 9 to 12. But how quickly does rimegepant become effective? As we've seen, it is effective at 9 weeks of treatment. Well, as fast as it is for acute treatment, is also quite fast in prevention, I would say, because does show in the clinical trial that is able to provide a 30% reduction in weekly migraine days already in the first week of treatment. So you can expect from Nurtec as a prevention, a 30% reduction in migraine days already in the first week compared to placebo. And how does the rimegepant compare against the other preventive medications, the monoclonals, for example? There are no head-to-head trials, or better, there was no trial, because just recently, a couple of days ago, it was published in a trial against galcanezumab. But these are data that are not comparing head-to-head these molecules. These are the data from each individual single trial. So this is different from a head-to-head trial. This is what is called a network meta-analysis that show that overall speaking, both the monoclonals and rimegepant are able to show similar efficacy at week 12 of treatment. So after 12 weeks of treatment, they do show the same excellent reduction of monthly headache days, both in episodic migraine, well, chronic migraine for the monoclonals. Rimegepant, you have to remember, it's approved for the prevention of episodic migraine only. But both rimegepant and the monoclonals are able to reduce significantly the same number of monthly migraine days at 12 months. But still, there are some pros about rimegepant when we want to start a patient on a preventive medication, because we can use to our advantage, for example, the short half-life. We know that the half-life of rimegepant is 11 hours only, over basically 20 days for the anti-CGRP monoclonal antibody, which means that if you have an allergic reaction that can always happen, hypersensitivity, or any kind of adverse event, you stop the medication, it will be very quickly washed out from the body of the patient, differently from what is happening with the monoclonals. They stay for long. Or if the patient, young female, which are the majority of patients in clinical practice, want to plan a pregnancy, or by accident discover to be just recently pregnant, you know that discontinuing Nurtec will allow in less than 2 weeks to be completely drug-free in the system, while with the monoclonals you can need up to 5 months to be completely washed out. Oral administration can be preferred for certain patients that don't like injections, or they've got a needle phobia. There are no contraindications in the use of rimegepant in patients with stable cardiovascular or cardiac risk factors. And there is no association at the moment with elevation of blood pressure, as has been, for example, pointed out for the monoclonals. Tolerability is comparable to placebo, as we've seen, and there is no evidence of wearing off effect in the last week of treatment, for example, as instead we do know sometimes happen with the monoclonal antibodies. In the long-term safety study, which was a 52 weeks trial, open label long-term extension after the double-blind trial of 3 months on rimegepant, patients were able to use rimegepant not only daily, but not only every other day as per the protocol, but also daily as a PRN. And the most interesting data from this extension was that no patient developed medication overuse. So even if they were taking daily doses of rimegepant for up to 1 year, they never experienced medication overuse. Actually, all of them documented a further improvement and reduction in the baseline change of monthly migraine days at the end of 1 year of the study. What about safety and tolerability? As we have heard just recently with monoclonals, there can be some issues. In terms of side effects and adverse events, the most commonly reported adverse event on rimegepant was nausea. And using rimegepant as acute phase treatment, nausea can be expected in 2% of the treated patients compared to 0.4% of nausea reported in placebo. If Nurtec is used as a prevention, instead nausea can be expected in up to 2.7%, so still a very small percentage. Abdominal pain and dyspepsia are reported only in those patients that are taking Nurtec as a preventive medication. Is not reported in patients taking it episodically for acute phase only. And still, the percentage of patients reporting any kind of abdominal discomfort is quite low, 2.4% of patients only. So rimegepant 75 was not associated with any serious treatment-related adverse event. Rate of discontinuation due to adverse events, very low. Less than 2.7% of patients across all the acute and preventive trials had to discontinue Nurtec because of adverse events. Going to the conclusions, how Nurtec can be used, how Nurtec can be prescribed. If you want to use it, if you need to use it as an acute phase treatment only, you can prescribe, for example, a single box that contains 8 tablets that can be used as PRN, so as needed in case of an attack. You have to inform the patient there is no need and should not take a second tablet in the same 24 hours. But if there is, for whatever reason, a new attack the next day, he can take a second dose because that will not cause any different side effect, nor will trigger any kind of medication overuse. Although you can probably expect a sustained pain freedom and pain relief up to 24 or 48 hours with a single tablet. If instead you need to use Nurtec as a preventive medication, the way to prescribe is to prescribe Nurtec 75 milligrams every other day. So must be taken 1 day yes, 1 day no, alternating days for as many months as can be necessary. So the patient will need a prescription of basically 2 packs of 8 tablets each. So you can modulate and really customize, you can make a bespoke treatment for your patient with one single molecule and medicine. So summarizing, Nurtec ODT is the first and only dual therapy proven to treat acute and proven to prevent migraine attacks. Can be used as necessary to stop a single migraine attack. It's oral dispersible, so even for those patients who experience nausea or that will later on suffer from vomiting, the oral absorption is, of course, much more preferable compared to a tablet that has to be swollen. And with this single molecule, we really can now dissolve the line between acute and preventive treatment for migraine. With one medication, we can really treat both phases and stages of migraine. In terms of safety information, of course, if there is any evidence of hypersensitivity, Nurtec must be stopped and cannot be started again. Adverse reaction, we have said already, 2.7% of nausea when used as prevention, 2% when used in acute, and only for the patients that are using this as a preventive medication, 2.4% of abdominal pain or dyspepsia. Hypersensitivity and rash were documented in less than 1% of the patients. Drug-to-drug interaction, this also has to be kept in mind, although it's quite unlikely with our kind of patients suffering from migraine, but should be used with caution or avoided if the patient is already taking a strong inhibitor of the cytochrome P3A4, like ketoconazole or rifampicin, or the inducers of the cytochrome P3A, because the inhibitors will increase the plasmatic concentrations of Nurtec, and the inducers instead will reduce the plasmatic concentration of Nurtec itself. So if instead the patient is not taking a strong inhibitor or a strong inducer, but is taking a mild or moderate inhibitor, the only recommendation is, if there is the need to take a second dose of Nurtec, can be taken, but it is advisable to keep a 48 hours interval between two doses of Nurtec. There are no data at the moment that can allow us to use Nurtec in pregnancy or in breastfeeding women. So at the moment, this is not approved and cannot be recommended. And finally, about hepatic and renal impairment, is recommended not to use Nurtec only in patients with severe hepatic impairment or end-stage renal disease. Otherwise, Nurtec can be used safely. Thank you for the attention. I know it's quite late for people with the same latitude, and we'll give back the stage to Dr. Riva.
Thank you. Thank you very much. This was very comprehensive. I guess I have a few questions. I'm just going to remind our viewers and our followers to put their questions in the question and answer so that we can put them across to Dr. Teruzzi. The first question I have, because we were talking about the adverse events, from your own practice, have you seen anything outside of those that we have mentioned today, from your own practice?
Sure. So if we're talking about the Japans, of course, the experience is a little bit more limited because we received Japans, as you know, only at the end of Rivaroxaban was approved in the UAE, for example, at the end of 2022. And so it's more limited compared to the experience that we have with the monoclonals. But so far, I must say that the tolerability and the safety of the Japans is absolutely good. I had a very limited cases, a couple of patients reporting some dizziness or nausea, and no patients so far that had to discontinue because of side effects. So tolerability in my clinical practice has been very good. Although I must admit that also with the anti-CGRP monoclonals, I haven't had and I haven't met any adverse event so far. I had only one in 5 years allergic reaction on erenumab, one allergic reaction on galcanezumab, and I think 2 patients that had severe constipation with erenumab in 5 years. So I must say that in my personal experience, I didn't encounter the major or significant adverse events. It's also true that sometimes we do not ask. So probably if we would be more, dedicating a couple more minutes, making the right questions, probably we could get more interesting information.
So in our practice, or in my practice, what we do when we are starting a CGRP monoclonal antibodies, we start them with magnesium citrate at the same time, not ahead of it. And that is to mitigate or to reduce the effects or the side effects of constipation. I don't know if this is something that you utilize as well, or do you use
Interesting.
it?
No, honestly, no. What we do, of course, we do recommend, well, first we ask if there is constipation. Sometimes they say yes. And then you ask, okay, but what do you mean with constipation? Oh, I go every other day. Well, that's not constipation. So it depends on the physiology of the person, but we do recommend to increase the amount of fibers and hydration, especially because, of course, for us in the Middle East, this is quite an issue, the hydration because of the hot weather. So we always recommend and make very strong education about this. And if the patient does notice constipation, of course, they have to come back to us and then we decide what to do. So far with physical activity and diet, small advices, we were able to manage it most of the times, but also the use of medium citrate, I think, could be a smart shot to be considered. I agree.
I think it's also, I have a question from one of our viewers that is asking about magnesium specifically. The person is asking, magnesium deficiency can affect neurotransmitters and restrict blood vessels. This factor can give a migraine. Do you feel that this is a cause of a migraine?
So this is a very interesting question because we do use magnesium. We know that, for example, in pediatric migraine, it works beautifully. In adults, maybe not so dramatically, but does work. We use as a first-line treatment sometimes in patients that are not very keen on starting a drug. Medication, proper medication, or we use it as an add-on when, for example, we have only so-and-so results with a conventional oral, for example, standard care medication, and we must say that it works. I don't think that is related. I mean, we do know that it's not related to the plasmatic levels of magnesium. So there is no point in checking in a plasmatic magnesemia, for example, because that's not the way it works. How it works, that is more challenging question. Probably does work. Not convinced about the vascular tone, which we do see, for example, in vasospasm from SIH. But in that case, we give IV magnesium to try to minimize vasospasm together with nimodipine. On migraine, it's more probably a matter of transporters more than vascular tone.
And we know that it's the intracellular magnesium that is affected in a migraine attack. It's not the circulating. So I agree with you because most of my patients say, so can I just go and do a blood test to find out if I need magnesium? And we do have signs.
No.
And I say, no, you're wasting your money because it's not going to really give me an idea. What we do recommend is there are signs and symptoms. So if you're waking up feeling really tired, even though you've slept the 8 hours, it means you're not getting restorative sleep. This is one of the reasons why I would add magnesium. If it's a female that is having severe cramping around their period, that's another sign. Muscle spasms, cramping is another sign that we possibly will benefit from adding magnesium. And as you said, bowel movement. If someone has constipation, it might be that there's a need for us to add. It might be that the bowels are spasming as well. They're not really having a normal rhythm, and we add magnesium. But in terms of a reason, this is not a reason. This is a neurovascular condition that possibly magnesium plays a role in the neurotransmission of signals, but it's not why you have, or at least that's as far as I know. Which medication? Okay, this is very interesting because this is a big factor in North America, and that is coverage.
Yes.
These new medications are expensive, and our viewer here is asking, what do you do if someone does not have insurance that covers Aimovig or Nurtec, and you still want to give them something that is effective? Do you go back to the old ones now that we know we have?
Well, if the patient cannot afford, because not having insurance It depends. If the patient can afford, we can still challenge a monoclonal or onabotulinum toxin. As we know, they are approved for chronic migraine treatment. Nurtec is not approved for chronic migraine prevention. It's approved only for episodic migraine. Atogepant is approved for chronic migraine also, but Nurtec is approved for episodic. If the patient cannot afford, he doesn't have insurance and cannot afford a monoclonal or a anti-CGRP or a CGRP receptor antagonist, then of course, yes, we have to consider oral standard of care, so the classical preventive medications. Onabotulinum toxin, if it's more cheaper, but then again, it depends on the healthcare system, still is quite expensive. Probably nearly as expensive as the monoclonal by the end of the year, so not sure if it can be an option, although it does work beautifully for migraine prevention. So for the oral preventive, I would say topiramate is the one that has also clinical trials in chronic migraine treatment. And then, of course, I mean, in that case, you are allowed also to step back also to the other medication. So it doesn't mean that you cannot try a trial with amitriptyline, that old poor amitriptyline still works quite well. So can be worth trying. I would say that if you fail on the most of the common already used one, valproate can give amazing results, but you have to be careful because it's quite a challenging molecule. You have to be careful about the side effects. Young ladies, of course, you don't want to put them on valproate, but can also be eventually an option. So definitely, yes, you can go back to the conventional topiramate and beta blockers, amitriptyline, and the standard oral of care.
And, you know, one of the medications that is really underutilized in this condition is candesartan, that has good results and totally gets forgotten by primary care physicians. It is affordable because it's generic at this point of time. And we do see really good results, but we see very, very few patients tried with that.
Yes, that's true. Sorry. No, I'm here.
Okay. The next question I have is also very interesting, and the question is around neuromodulators. The person who's asking is asking specifically about Nerivio. I wasn't aware that Nerivio is available in UAE. I know it's not available in Canada, but is available in the US. Is it available in the UAE, Nerivio?
I'm not aware of that. We do have available Cephalid and recently the Gamma Core. Yes. I'm not aware of Nerivio availability, honestly, at least in Dubai. I don't know if it's available in other Emirates. So with the neurostimulators, I think that can be an excellent option, for example, for certain categories of patients, pregnant women. For example, Cephalid is absolutely a good call. Can also be recommended for those more challenging patients that do not achieve good or complete resolution of their migraines with the medication, and they cannot, for example, increase the dose because of tolerability or side effects. And you can always combine with a peripheral modulating device. And the advantage is, of course, the tolerability and the basically lack of side effects, but some discomfort. The problem is the cost, because those devices are not approved 100% by insurances, by policy, by default, and I think it's the same in the US. So the patient has to basically pay for it himself. The same is in Europe, also in Italy. They were not available to the healthcare system, and even here.
The next question is again back to magnesium. I think we have a lot of pharmacists as well in the group. They're asking, which salt of magnesium do you use? Which one do you like?
It depends which one you have available also. Sometimes you can use magnesium pidolate, you can use magnesium titrate, threonate. It depends. Honestly, it's very... Sometimes it's not easy also to find the ideal one. It depends what is also available in your pharmacy or in your country.
Okay, I have
magnesium oxide, magnesium citrate.
So in Canada, we do not recommend oxide because we feel that the absorption is not
gastrointestinal,
as
yes,
good
for the
and it does
gastrointestinal.
upset the stomach. So we usually
Yes.
use citrate or glycinate or bisglycinate. Citrate if someone has constipation, but if someone doesn't have constipation, we go for glycinate because it's a little bit softer on the stomach. We still say take it with food because it does upset the stomach in any form. And the threonate is studied a little bit more in dementia, but they're really, really small studies. And I don't know of any study in migraine, but I do recommend it for my patients that have brain fog. So if someone comes and they say, well, I'm not able to focus, I'm waking up really, really foggy, I can't concentrate at work. For cognitive function, and I do have, again, anecdotal, it's not, there's no clinical trials, they say that it does work. A little bit more expensive, so I feel guilty to tell someone, yeah, why don't you take this, it's going to cost you like $100 a month just to take magnesium, when the glycinate will work very well and is tried, is going to cost you something like less than $20 or whatever. So it's more expensive, the threonate. I have
Usually we use the citrate in our clinical practice, and also with the combination of B6.
Yeah, B6. So we do B2. We do riboflavin, and that is 400 milligrams.
Also, yes.
Over B6, but I understand B6 can help with nausea, maybe a little bit. I have one last question. I have two actually, but I'm going to go. I'm not sure if this is Dr. Monanada. I'm not sure if it is, but the question is around compliance. From your practice, which one of the anti-CGRPs has more patients compliance, knowing that one sub-Q route and the oral route every other day, they are different. Which one and for how long do you keep your patients on Nurtec as prophylaxis?
Right. This is a beautiful question. There is no golden rule and there is no carved into stone recommendation. You have to discuss this with your patient, I would say case by case. There are patients who are happy to take, for example, Nurtec every other day. They just put a reminder on their mobile and they can manage. So without big issues of forgetting about taking a tablet, because it's not every day. So it's a little bit less intuitive than a standard treatment, but with a mobile phone or a smartwatch reminder, I mean, case closed, and they're happy to do that. Other patients are actually happier to take one medicine, let's say once only per month in the 4 weeks. So they prefer to go for the sub-Q injection. And other patients actually are happier to take the IV route that is only every 3 months. So I must say that honestly, it's really case by case. You have the option nowadays to customize your treatment on your patient's need. So you have to spend 5 additional minutes of your time to be able to identify the right profile of patient to offer to him the right medication. He will be happy. He will come back to you. He will not give up or drop off from the medication if you selected him well.
I think this communication and involving patients in treatment option actually improves adherence. So anyway, if you talk to them, find out what they prefer, you have a higher chance of compliance and adherence versus telling them, by the way, this is what you need to take, or sending them with a prescription without having that discussion. I find that it works very well when I say, these are your options. There's no head-to-head studies. We might have to actually try more than one, but which one appeals best to you? And I find that they, number one, advocate better with the doctor when they know that they are participating in the decision, means that they are more likely to actually go on and use the medication and come back and give feedback. I don't know if there's an impact on even results because they feel more motivated. We know that placebo is very high with migraine. I don't know if even the success of treatment improves with that participative and them participating in the decision making. So I agree with you. It only takes an extra 5 minutes to talk to them. But I know that when we first had the CGRPs come out and we were like once a month, people were like, yay, once a month. And then we again had the G-Pen saying oral. People were like, oh, thank God we have oral. There will always be the new shiny solution that works. And there's no one size fits all, specifically for migraine, because of the complex nature of migraine. This is something that we know is very difficult to gauge. I think Maya is telling us to wrap up. Dr. Tirutsi, it was a pleasure having you. Thank you very much for your presentation and for joining us tonight.
My pleasure, and thank you, Pfizer. Thank you, IVPN, for inviting me tonight, and thank you to all the audience for staying so late.
The same. I will join you in thanking everybody. It's almost 10 p.m. in parts of the world where we are sharing this tonight. It's still noon in it's 1:46 in New York and in Toronto. Thank you very much. Thank you for IVPN. This is the last one of the 6 series that we have started. I know Dr. Maya has some announcements for you. Thank you very much, and please continue to follow IVPN and go to our website. Association of Migraine Disorders resources are also very rich. So if you need to learn more, please go there and join us, communicate with us, tell us what else you would like to hear. And we're very happy to have had you here tonight. Have a very good night.
Thank you. So I would like to thank Hiba, Dr. Hiba Bani Hani, who is a migraine pharmacist specialized in migraine. And actually, you can tell from her moderation that is very passionate about this disease. And we are always happy to host her as a moderator and as a speaker to share her expertise in the field. So thank you, Dr. Bani, for being with us and for supporting us in sharing education and awareness about migraine disease. Also, I would like to thank our speakers, Dr. Robbins, Dr. Tirutsi, for accepting our invitation. Also, the big thank you goes for Pfizer, our sponsor, who are supporting us in organizing this migraine masterclass series. I would like to remind you that you will receive your certificate of attendance by email within 1 week of today. And if you missed any part of this webinar or would like to revisit any of the previous or this masterclass, you can always visit our IVPN library, where the recording for all the migraine masterclasses and other educational activity are posted there. And currently our IVPN library is accessible free of charge for all those who would like to watch again the recordings. Finally, I would like also to encourage you to keep following us on our social media platform, where we post all our activities and news. I would like at the end to thank you for all our attendees for, as Hiba mentioned, staying with us for joining us and staying with us until the end of this webinar. And we will be continuing this very successful series of masterclass, given the success, their success. So our 7th migraine masterclass will be scheduled on July 24th. So book your calendar and save the date, because on July 24 we'll be discussing a very, very interesting and hot topic in migraine, which is the treatment of migraine in pediatrics in the current era of CGRPs and monoclonal antibodies. So save the date for July 24 and keep your eyes on our social media platforms, where all the details about registration and scientific program will be announced very soon. Until I meet you again, stay safe and have a good night.